All right, guys, so today we're going to finish up the last of the lectures for this course. So we're going to go over chapter 51 and 53. Those are both out of your Med-Surg book. So make sure that you use your Med-Surg book to study for this part of the class, okay? So the first chapter that we're going to talk about is going to be chapter 51, which is covering breast conditions. So breast cancer screening guidelines, I need you guys to know that these vary. You need to kind of be aware of current evidence-based practices whenever you're looking at the screening guidelines. So for example, your HESI book says that baseline mammograms should be done every 1 to 2 years when patients are in their 40s and then annually when they're in their 50s. But the U.S. Preventative Task Force says that it should be an individual's choice to have mammograms before the age of 50. The American Cancer Society says that they should do it yearly between the ages 45 to 55. And so as you can see, they all are going to vary. Okay, so whenever you're looking at this, just be aware that guidelines are going to change based on the most current evidence-based practices that are going on. Okay, but overall, women who are at an increased risk most often have earlier mammogram screenings. So things that are going to put women at more risk are going to include a family history of some sort of breast condition, genetic links, prior breast cancer, or any atypical findings on a previous breast biopsy. So if any of those things happen, we're going to see them have a mammogram earlier. And a mammogram is simply an x-ray that allows us to see those internal structures of the breast. So breast self-exams are performed monthly by the female, and these can help to facilitate breast self-awareness, okay? We're going to talk about the different methods that are used and the different techniques that can be used. But it's very important to understand that the goal is that the woman does the same thing each month so that they can identify any different changes. Okay, they're self-aware of if they feel a nodule or they feel a lump or they feel like just something isn't right. The woman is able to identify that versus using a different technique each month and never being able to find those issues. Okay. Just a few side notes, we can still allow for early detection on changes. So this may mean that maybe the woman isn't going to her physician. Obviously, we don't go every month. And so maybe through those times in between her annual screenings, she is performing these breast self-exams and they can early detect any nodules or lumps or things that they may notice. Okay. Benefit in reducing breast cancer deaths is still controversial. There's just not been a lot of studies done to prove that this can or cannot reduce breast cancer. But it is important to allow for early detection of the changes, and so therefore should be continued. So next, we're going to talk about how to perform. So we need to make sure that the woman is performing her breast self-exam monthly after the menstrual bleeding ceases. Okay, it's very important to be done after menstrual bleeding. We do not want this woman to do it during her menstrual cycle because during that time, we have increased hormones, and those increase in hormones, as we're going to talk about in a few moments, can cause some changes in the breast. Okay, so after the bleeding ceases when the hormones are the lowest. So this is done by first inspecting the breast. So the woman should stand with her arms at the side, lift her arms above her head, and also put hands on hips while leaning forward. Okay, this allows the woman to just see any abnormal contours. We look for color and venous patterns. If we notice that there's some changes in color, that could indicate an increase in blood flow from a tumor. Okay, and so that would be a way that we identified something abnormal. We also want to look for thickening or edema. They may have enlarged pores or an orange peel look, and that orange peel can tell us that we have some sort of edema in the breast. Okay, something is causing that dimpling and the changing. And I don't have a picture of it on here, but I urge you guys to look up what that orange peel looks like. Okay. And then we're seeing those skin dimplings, puckering, or any retractions of the breast. Okay. Next, the woman is going to do the palpation portion. With palpation, they should lie flat, put one arm behind their head to spread that tissue out evenly. We want to educate them to use their finger pads of their 3 middle fingers. And they can either use the up and down motion or circular motion, but the idea is that they will either go up and down the entire breast, back and forth until they have gone side to side, or they can move in a circular motion and move out. With that, they could palpate if there was any nodules that they felt. After laying down, we want them to stand or sit and repeat with the hand above the head, just to make sure that the lump was not somewhere that was not easily detectable when laying flat. Okay. So benign breast disorders, the first one we're going to talk about is mastalgia. So mastalgia is breast pain or tenderness, and it's most commonly related to hormonal sensitivity. So this typically occurs with the menstrual cycle, and there's nothing that we can do to treat this. Okay, it's going to subside after the menstrual cycle. The mastitis, we've talked about this multiple times, but just know it's inflammation of the breast. We see red, painful, tender area, and they are placed on antibiotics, and we want these patients to continue to breastfeed. Fibrocystic changes, these are any changes to the breast tissue that are benign. Okay? They're thought to be caused from a heightened responsiveness of the breast tissue to circulating estrogen and progesterone. So these lumps are freely movable, okay, and they're round, and they're related typically to those hormones. Therefore, they occur during the premenstrual phase and will subside after menstruation. Okay, so this is one of those reasons why that breast self-exam is best performed after the menstrual cycle. Okay, after those hormones have decreased. So this is just a little picture of those fibrocystic changes that we were talking about. So you can tell on picture A, the breast tissue is just normal. We don't see any nodules. But then B shows you those fibrous tissues, okay, that are kind of have some irritation from those increase in hormones. Okay, those are going to be able to be moved around, and they're going to go away after the hormone decrease. Fibroadenomas are small, painless, round, mobile nodules within the breast. They're solid and firm. They're the most frequent cause of breast masses in women under the age of 25. The size is not affected by menstruation, and they're benign, so they're typically just left alone unless we see some sort of malignancy that develops from the fibroadenoma. But as long as it's benign, we're going to leave these alone, and they are not affected by menstruation. Therefore, they're not going to get bigger or go away after the menstrual cycle. They're going to stay regardless. Nipple discharge, this can be serous, bloody, or brown to green discharge. Our goal is to determine the cause and our recommended treatment. Usually it's from a benign breast condition such as fibrocystic changes or some sort of ductal ectasia problems. Okay, so it's usually not related to a malignancy though, so that's a good thing. Here we're going to talk about a little bit of geriatric considerations. So with geriatrics patients, we have a loss of subcutaneous fat, a loss of structural support, atrophy to the mammary glands, and a decrease in that glandular tissue. That glandular tissue decrease makes breast easier to palpate. Okay. This is why we start mammograms later. okay, because we can easily palpate that tissue. We also have the loss of the structural support and the loss of the subcutaneous fat, and that atrophy of the mammary glands all contribute to an increased incidence of breast cancer. So we want to make sure that these patients are getting screened properly so that we can detect breast cancer early on. Your book really talks a lot about breast cancer, but for the sake of this class, there's just a few really big things that we're going to talk about. And so make sure that you follow your notes and only focus on what we talk about, because it goes very into depth on the different types of cancers and some major changes. Okay. So the big thing I want you guys to focus on is going to be the risk factors, our clinical manifestations, and surgical therapy and the nursing care that goes along with that surgical care or surgical therapy. Okay. So let's talk about risk factors. These are all in table 51.2 on page 1209 in your Med-Surg book. We look at family history, any environmental factors and genetics, early menarche or late menopause. So if they started the period earlier or went into menopause later, it's going to increase their risk of breast cancer. Increase in age. On here it says 60, your book says 50, so just know that the higher the age, the more risk. Okay. Patients who have had hormone use have a genetic link, such as the BRCA gene. And this is just a little side note that I think is very interesting, but everybody has BRCA genes. BRCA genes work to suppress tumors. Okay, so whenever we say that the patient has a positive BRCA, that means that there is some sort of mutation of the genes that is going to increase the risk of breast cancer. Okay, so I just think that's kind of cool that, you know, you always hear people talk about the BRCA gene, but everybody has one. It's just a matter of if you have the mutation of the gene. And if that gene is mutated, it's not going to suppress tumor, which is going to increase your risk for getting breast cancer. And then modifiable risk factors include excess weight gain, a sedentary lifestyle, smoking, obesity, and alcohol intake. Okay. There are many different classifications of breast cancer. I don't want you guys to focus on memorizing the differences. Just realize that our different interventions are going to be based upon the type of breast cancer that the patient has. Okay. So we're going to look at these clinical manifestations. We look for a lump or thickening in the breast, any dimpling of the skin or changes in the skin texture, and that's known as the peau d'orange or the orange peel. Okay. And also the presence of a hard, irregularly shaped and non-mobile palpable lump or tumor. Okay. For us to diagnose breast cancer, we have to have a definitive diagnosis with a biopsy. And another fun fact with breast cancer is that it usually occurs in the outer upper quadrant because that's where the most glandular tissue is located. So there are different areas that really heighten the chance for breast cancer occurring there. This is a picture of what I'm talking about. So we look in this upper outer corner where it's 50%. So that's a pretty high incidence of breast cancer in that tissue. And it's just because of the high density of that glandular tissue. Interprofessional care is not listed on our PowerPoint, but there is a table 51.5 on page 1213 of your book to review. It really goes over what we're about to talk about with the surgical therapy and the hormone therapy and just generalized nursing care, but it's condensed into one table, so make sure that you review that. So in the event that the patient needs surgical therapy, there are different types of mastectomies that can be performed, okay? And so don't focus on these pictures. I don't want you to be able to identify, looking at a picture, which surgical procedure the patient had, but more realize that the outcome is affected by the type of procedure that they had to have done. Okay. So the first type of surgical therapy is going to be the lumpectomy. And this is removal of a tumor in a small margin around that normal surrounding tissue. Okay. So this would be kind of like picture A, where we only go in and we take that tumor and a little bit of tissue around it. We leave everything else alone. A total or a simple mastectomy is going to be removal of the entire breast. Okay. They can do a radical mastectomy where they remove the breast tissue and the axillary lymph nodes, but preserve the pectoralis muscle. Okay. So that would be like picture C over here, where we're taking all of that tissue and all of the mammary glands, but we do leave the pectoralis muscle. Okay. And they can also do nipple sparing, so sometimes they have to either take the nipple, but there are times whenever they are left in place and the breast tissue under is removed. Okay. So again, don't focus on knowing the exact things that happen with each one, but know that it's going to affect their care. For example, if a patient just had a lumpectomy, we're not concerned about lymphedema, okay, because we did not mess with the lymph nodes. However, if the patient had a radical mastectomy and we did have to mess with the lymph nodes, then we are going to have to make sure that that patient is a limb alert and prevent lymphedema. Some alternatives to care include radiation, chemotherapy, and sometimes we can do hormone therapy. Again, realize these are going to depend on the type of breast cancer, the stage at diagnosis. Sometimes they may have to do radiation and chemotherapy before they have the mastectomy. We have to shrink the tumor so that we can actually remove it. We have to look at hormone therapy and knowing if that tumor is estrogen positive. Okay, if that tumor is estrogen receptor positive, we cannot treat this patient with estrogen, okay, because therefore we're just going to be feeding that tumor. Okay. However, there are some hormone therapies that block the effect or the source of estrogen, and so therefore we can promote tumor regression. Okay, so if that patient needed that done, we can actually kind of stop the growth of that tumor by giving different hormones. Okay. This is the big thing that I want you guys to focus on here is going to be nursing care, because this is what you as a nurse are going to be doing for these patients. So the number one is going to be pain control. These patients after surgery are in a lot of pain, okay, as with any surgery, and so we need to control their pain. They can still have phantom pain, so they may still feel pain in that breast even though that breast tissue is gone. We want to have them elevate their arm on a pillow, okay, to try to keep blood flow and avoid any edema. Okay. We've talked a little bit about lymphedema. That's the biggest risk. We need to know after surgery if any lymph nodes were affected, because if so, that patient needs to be a limb alert. We have to avoid any IV sticks, any blood pressures, or any trauma to that arm to ensure that we don't impede the blood flow or the lymphatic flow. Okay. There is a box in your book about home drain care. So those patients, if they have to go home with a JP drain. So make sure that you review that. Everybody has done the women's health prep, and so you guys have all had to look at that box. Make sure you review it again before your exam. And then lastly is post-op arm and shoulder exercises. We want to start these gradually, but these exercises are going to be started before discharge from the hospital. They're going to help us to prevent contractures and prevent muscle shortening. We want to maintain that muscle tone. And they're also going to help us to improve lymph and blood circulation. Okay, So these patients in the hospital are really very independent after surgery, and that's their expectation. I always find it really interesting that we have so much education before surgery that the education after surgery is very minimal. These patients already know how to take care of their JP drains most of the time, or how to care for their incisions, and they've learned about their exercises to be doing. And I think that's very important for the nurse just in the postpartum period. I'm sorry, not postpartum, post-surgical period, to reiterate that to the patient. Okay, we need to ensure that they know how to control their pain and how to care for that drain, because they've learned about it before, but now it's a reality. Okay, so we really have to care for those patients. Here's just a picture of lymphedema. So this is what could happen if we have affected the lymph nodes and then a blood pressure is taken on that arm. Okay. And then this is a picture of some post-operative exercises that we want this patient to be doing. Obviously, they're not going to be able to do all this the second they roll out of surgery, but by the time that they are discharging and they get home, they should be starting to perform these exercises. So that's all on chapter 51. Our very last chapter is 53. Some of this stuff in this chapter we've already covered a little bit before, so I'm going to skim over some of it. And then there are also a few things that come out of your HESI book. So I really try to pull any HESI hints. When you're looking at this stuff, it's going to be in your HESI book under your med-surg section. Okay, it talks a lot about cervical cancers and endometrial cancers that you will most likely not see on the OB portion of your HESI, but it is a chance that it could pop up on your HESI, okay, for med-surg. And then also, you will be tested on this information for my class. So review your HESI book and review this chapter and the specific cancers that we talk about before your final exam. So the first thing we'll talk about is going to be Pap smear guidelines. So I want you guys to understand that Pap smears are specifically done every 3 years, okay? And this is when they go in and we're going to scrape part of the cervix to get some cells, and those cells can be analyzed under a microscope, okay? Again, these are done every 3 years, but women are still encouraged to go to their gynecologist for a pelvic exam every year, okay? The Pap smear is only looking at a very few things like we're going to discuss when we talk about different cancers. And so to detect other cancers or other issues, the woman still goes every year, or should go every year, to their gynecologist, okay? So with Pap smears, it's going to be a lot like breast cancer. Their recommendations are going to change all the time based on different organizations or different best practices, okay? Typically, they start at age 21, and most often it is not recommended to screen before the age of 21, even if the patient has been sexually active. Okay. And then by the age of 65, we stop Pap smears. So the first issue that we're going to talk about is going to be pelvic inflammatory disease, or PID. So this is the infection of the pelvic cavity that can involve the fallopian tubes, the ovaries, and the pelvic peritoneum. It can also form tubo-ovarian abscesses. It's a result of untreated cervical infections such as chlamydia or gonorrhea. Clinical manifestations include lower abdominal pain that increases with movement, pain with intercourse, and sometimes purulent vaginal discharge is seen. Complications from PID going untreated can include septic shock, the abscess formation that we talked about, and peritonitis. Okay. In the end, this can also lead to adhesions and strictures in their fallopian tubes that can cause ectopic pregnancies. Okay, so PID increases the risk for an ectopic pregnancy. To treat this, we give antibiotics. Sometimes this is done outpatient unless the therapy is not working or the abscess forms where we have to give IV antibiotics. We treat it also with heat and sitz baths. And we want this patient to be in bed rest in semi-Fowler's position. Okay, being in that semi-Fowler's position promotes drainage in that pelvic cavity. Okay, so antibiotics, heat and sitz bath, and we want to put them in bed rest in semi-Fowler's. Okay. Benign uterine tumors is discussed in your HESI book. It includes leiomyomas, fibroids, and fibromyomas. The most common symptom that we see with these uterine tumors is abnormal uterine bleeding. Treatment with a DNC or an ablation if that bleeding is extreme. If we have these fibroids with excessive bleeding, we may have to look at doing a myomectomy, which is where they actually go in and remove the fibroids. Or we may have a patient have to have a hysterectomy. And there are also some hormones that can be used to try to shrink those fibroids or those tumors on the uterus. So let's talk about the different cancers. So we're going to go over cervical, endometrial, and ovarian cancers. And be aware of the different ways that we detect them, what puts the patients at risk, and also the symptoms, okay, because you're going to notice that symptoms change whether it's early or late diagnosis. So with cervical cancer, early detection with pap smear is key. Okay, that is the only way that we're able to detect cervical cancer in the early stages. Risk factors for cervical cancer include human papillomavirus, or HPV, immunosuppression, having a chlamydial infection, and smoking. Symptoms for cervical cancer, in the early stages, there's no signs. So it's very hard to diagnose in those early stages unless we have a pap smear. In the late stages, we can see some unusual discharge, maybe a little bit of abnormal uterine bleeding or bleeding with sex. And in the very late stages is when we actually start to see the pain, some weight loss, and anemia. Okay. We talked about pap smears, so we want to ensure that we educate these patients to start getting pap smears at age 21. There are vaccinations for HPV, including Gardasil and Cervarix. The CDC recommends starting these at age 11 or 12. Okay, so it's very early. There are a lot of controversial discussions about the use of these vaccines and treatment, but be aware that they do exist, and it is a treatment that should start early because we know that teenagers are becoming sexually active earlier and earlier, and with being sexually active, we increase our risk for HPV, okay? And we know that HPV causes cervical cancer, okay? Chemotherapy is not useful for cervical cancer. And so in the early stages, they can do the LEAP procedure where they're able to kind of go in and cauterize some areas of the cancerous cells. Or in the late stages, we can see some radiation or pelvic exoneration. With the pelvic exoneration, they literally take everything out of the pelvis. Okay, some of you guys who were in women's health this semester saw some patients that had this procedure done. So they have a colostomy, they have a urostomy, and so they have no more uterus, no more ovaries, they don't have a bladder, okay? The next one is endometrial cancer. So there is no routine testing available for endometrial cancer. It's usually just the signs that start to appear. And it's diagnosed early in postmenopausal women because they begin to have bleeding. So they haven't had any bleeding for years, and all of a sudden they'll start to have abnormal bleeding. So they're able to diagnose that. But in younger women who are still having a menstrual cycle, it can be harder to diagnose. Risk factors include exposure to estrogen, obesity, increased age, never being pregnant, early menarche, late menopause, family history, and smoking. Early signs of endometrial cancer are going to include abnormal uterine bleeding, and the late signs include pain during urination, pain during sex, or pain in the pelvic area. So the last cancer that we're going to talk about is ovarian cancer. This most commonly occurs between 20 to 40 years of age. The major risk factor is going to be a family history. It occurs if they have a mutation of that BRCA gene, or if they've had a personal history of breast cancer or colon cancer. Early signs of ovarian cancer shows no obvious symptoms. So it includes pelvic or abdominal pain, some bloating, urinary urgency or frequency, feeling full after eating, or weight changes. So as you guys can tell, those are symptoms that anybody can have on any given day. The late stages include abdominal enlargement with ascites, unexplained weight loss or weight gain, and changes to the menstrual cycles. Typically by the late stages, it has metastasized to the uterus, the bowel, the bladder, can go onto the stomach and the liver. So at this point, we do surgery if possible and debulking of the tumor. So the big thing I want you guys to know is the differentiation between ovarian cancer and cervical cancer. So remember, with cervical cancer, we're going to see some changes in bleeding. But with ovarian cancer, it has nothing to do with bleeding. Okay? Signs of ovarian cancer do not include bleeding. We could see a change to the menstrual cycle, such as, a period that's late or some spotting, a very light period. But however, that is not a sign of ovarian cancer. Okay, that's a sign of cervical cancer is the bleeding. Surgery and nursing interventions. The table of surgeries is on page 1260, box 53.15. And just to review that, I'm not going to test you on that, but just be aware of the different surgical procedures that can be done to correct cancers and other female issues. So after surgery, and our interventions include ambulation. We want to prevent DVTs. We want to encourage that patient to avoid intercourse or anything vaginally for at least 6 weeks. This is because whenever some of these surgeries are done, as we've talked about before with your prep works, is they can actually have a vaginal cuff. Okay, so after organs are removed, the vaginal cuff may be sewed closed, and with that, they're having intercourse or using anything vaginally, they could actually tear open that cuff and have a dehiscence. Okay, so we need to educate them, nothing vaginally. And then we also want to assess our patient's physical and emotional adjustments to their changes to their body, okay, especially if they've had drains or incisions. And then the last thing that we're going to talk about is pelvic organ prolapses. So just know the difference between a uterine prolapse, which is where the uterus is displaced into the vagina, the cystocele, where the weakened support between the vagina and the bladder, the rectocele, which is the weakening of the support between the vagina and the rectum. Okay, all of these prolapses can be fixed with surgical procedures. Some predisposing factors to an organ prolapse include multiparity, pelvic tears, aging, and obesity. Okay. Prevention of these prolapses include postpartum perineal exercises. We want to encourage patients to space their pregnancies and also weight control. And then the last thing I have is a HESI hint. So anatomically, the prolapsed uterus being displaced will cause some changes to that bladder, the rectum, and the small intestine. So they can actually protrude through the vaginal wall. And that's very important to realize that one slight change or one slight weakening can actually cause another organ to prolapse. Okay, and it's going to anatomically change things. Okay, so that's all that I have for you guys. That is all the content for OB for this semester. Y'all let me know if you have any questions in class.